This is a middle-aged patient presented with subarachnoid hemorrhage elsewhere and had this ICA aneurysm discovered, but nobody could offer her a treatment at that moment. And around the 10th day, she was referred to us, and any suggestion for this aneurysm? Any treatment plan?
10 days.
Yeah, 10 days out of her subarachnoid hemorrhage.
You think it's a blister aneurysm?
We thought it's a dissecting aneurysm. Yes, dissecting ICA aneurysm.
Yes.
We had exactly the same case that we published, and we treated with pipeline just in the basilar. So it decreased the flow enough, and the angiogram was done in like 2 months.
Yeah, perfect. Yeah, we had the same experience actually. And so we put the pipeline, well, we put actually 2 flow diverters in this case, and not the 5 pipeline though. This was a 2 frets, and it is gone. So even though it is not sitting on the basilar artery because the flow is decreased, it helps and it treats the aneurysm. It eliminates the aneurysm. Actually, I have another case. Oops. Yep.
You are anti-aggregation?
We put on the table, we gave prasugrel, and then we did the treatment.
And the level of prasugrel is complete?
Yeah, complete. Like we gave like 40 milligrams loading dose, and did the treatment, and 10 milligram per day then on after we placed the device.
You mean in the NG too?
No, just before the we have the patient just before the procedure.
How many hours before?
I mean, after we give the drug, the patient was put on general anesthesia, and we did the angio. It is like probably an hour before we place the device, I guess, because, half an hour it takes for the anesthesia to prepare the patient and then the angio, so probably 1 hour, but I know.
Now, if you're using Plavix, do you wait more?
Well, actually, we do not trust on Plavix, to be honest. So, and we do not believe its response, and also it takes much longer, 2 to 4 hours at least. So, at least today, I mean, nowadays, we always go for prasugrel for that purpose.
The majority of the people use Plavix. I want to make sure that everyone understands that they need at least 4 hours when they do it.
Yeah, exactly.
We did a relatively large number of patients where we gave Plavix to check when it becomes effective testing with the multiplate. You basically have no effect within the first 3 hours, so it takes 3 hours before you get anything.
Yeah, at least 4 hours.
We have been using ticagrelor, Brilinta, ticagrelor.
Yeah.
So I'm a little worried about prasugrel and hemorrhage. Have you had hemorrhage from prasugrel?
No.
Remote, not
No.
related to the treatment?
No,
Because that
not
is one
yet.
of, one of the contraindications for prasugrel is intracranial hemorrhage.
That's correct, but otherwise, I mean, if it is not effective, then there is no reason to give the drug, and we want it to be effective. It has higher risk because it is effective. That's what we believe in. And with Brilinta, it has, it has counteraction with many drugs like steroids, anti-epileptics, many drugs. So it is, and you need to give twice a day the Brilinta. So, I mean, I'm kind of hesitant because of the patient's accommodation to the treatment.
Isil, why you put 2 flow diverters?
Because it was a very recent bleeding, and we put Fred Jr., which is 48 strats. It is a little bit less than the pipeline. So we thought, because it has a very recent bleeding from a dissecting aneurysm, we worried about having another bleeding. That was the reason.
Because I have the same in another localization, I only put one flow diverter, and the aneurysm is still open. And my question is, I think it's very interesting, you put two flow diverter to close more the neck of the aneurysm.
Actually, in other situations, we do not like to put two devices at a time. But dissecting aneurysm is a kind of different story. Second case, okay. This is a very young girl, 10 years old, having paraplegia. She is on a wheelchair when she was brought to us. She has a terrible pain at the back, and the MRI showed spinal AVM. And nobody want to touch the patient, had twice diagnostic angiography elsewhere. And we decided to treat this patient, at least to start to treat the patient. Patient had having urinary and gaita retention. So, very terrible situation, 10-year-old. So, and she has this intramedullary spinal AVM fed by T4 the radiculomedullary artery coming off from the T4 and also from the costocervical, the radiculomedullary artery coming from the costocervical artery. And having this aneurysm and the anterior spinal artery is feeding the vascular malformation. This is just to show that the 4D angiography can show how much more and increase our understanding. Okay. Already. So it gives you image at any moment, at any angle, and moreover, you can take the advantage of MIPs so that you can dissect as thin as you want. And with those 4D images, because it was kind of tricky for those spinal intramedullary AVM, where the feeding is coming from, whether it's from sulcal artery or if there is enough space to catheterize and to give the embolizing agent without taking much risk. So it was very helpful for us, especially in those MIPs, we realized that This is the sulcal artery, only this amount, and then comes the big aneurysm. However, when you rotate it, we realize that from the aneurysm, the feeder is continuing and feeding, recruiting the vascular malformation. So we thought if we can go all the way distal to that aneurysm, we can embolize. We can embolize the AVM as well as eliminate this aneurysm, at least decrease the risk of the patient, although may not provide a cure to the patient. So we put guiding catheters into both arteries, costocervical and also T4. And from the T4, we put our microcatheter all the way to the aneurysm through the sulcal artery. See, this is the continuation of the anterior spinal artery. So we need to go to that sulcal branch, and then that's what we did. And we were finally able to catheterize the outlet of the aneurysm so that we can go more distal in that pedicle to safely embolize the vascular malformation as much as possible. And we did glue injection in this particular patient. And this is our cast, and this is the aneurysm that was creating the most of the risk, I would say, at least the acute risk. And this was the end result compared with of this session compared with the preoperative image, that we eliminated this aneurysm and decreased the vascular malformation a bit. And now at this point, we are planning to send the patient to CyberKnife. But interestingly, the patient got rid of the back pain immediately after her wake up, and she started to move her left leg, left foot, which she couldn't do before. She started to move her feet, which was very, for us, exciting. So hopefully it did some benefit to the patient. Any suggestion to move from this point on, or any suggestion, anybody suggesting something else? Yes? Yeah, Pascal.
In this case, just a quick question. Do you use provocative testing?
No.
In all those cases you don't, or in this specific case?
No, we don't use provocative testing.
Okay.
I would be a little worried to go beyond the aneurysm, because once you've closed the AVM, now your flow is directly into the aneurysm. So you close the aneurysm by retrograde flow, because you are beyond the aneurysm.
Yes.
So you are closing the AVM, but the aneurysm is still...
No. We came all the way till we closed the aneurysm. That was the idea. The first target was the aneurysm. However, we wanted to take the advantage of going a little bit, distal to the aneurysm, so that at least we can hit some of the AVM, and also there is not much segment proximal to the aneurysm before the anterior spinal artery. That was the safety reason, actually. That was the reason why we went distal.
The catheter was FM?
Marathon.
Which one is that?
Marathon.
Marathon.
Mm-hmm.
The patient is only half pain, not bleeding, no?
No.
Okay. Why do you think is the improve the patient? Why? Why improve after this embolization? Is the vein? Is the aneurysm?
The pain might be because of the aneurysm. That's what we thought. And we decreased the flow at least a little bit. I don't know how much, but I mean, here looks like we decreased the flow a little bit. So we thought it may be of help.
Okay, I have one case. René, ¿tú quieres presentar? ¿Tu veux présenter? Okay, I have one case, different localization. Is a young patient.
Easy for your case, it's very tough to go with the marathons to the address.
It was. But, I mean, we were lucky enough to find the outlet. I mean, if we couldn't, we were still to give the glue to eliminate that aneurysm anyway. But, you know. Huh?
Did you consider magic that rotates?
Yeah, could be. But at that moment, we didn't have magic. And marathon works very nicely, too. We like the hybrid wire very much for such, you know, you can direct it very nicely, and it worked in this case very nicely.
Is the theory of Albuquerque theory. Is hyperpression of the vein in the spinal cord. The theory of Albuquerque theory is a neurosurgeon from working in Paris, and describe one hypothesis, some case of paraparesia, chronic paraparesia, secondary to hyperpression of the vein in the spinal cord vein, and secondary to stenosis of left renal artery. And this period is just in the last century, is in 73. Don't have the imaging magnetic resonance, don't have possibility of the CT scanner, because it's only in this moment is the cranial CT scanner. And I have some case. I like to present one case of the very high pain in the back, and incoercible, very difficult to treat it. Okay. This is the theory. ¿Y ahora avanzo dónde? Aquí. Vale. Okay. This is the vein of the abdominal, and you are the left renal artery are communication with the paravertebral vein. In this part is the athygos. Just a minute. This is the schematic of Albuquerque theory. And this is the injection of the athygos, and you have the plexoparavertebral vein. And this is one case, you know, the hypertension in the spinal cord system drainage. This is the paper of Albuquerque in 76 with this doctor. Ahora está yendo para atrás. Okay. Just a minute. Another paper. And have the study is 77%, the 80 patient has venous abnormality, and this patient have a compression of the vein and have a paraparesia. The difference to the diagnosis, different diagnosis, sometimes is with the stenosis of canal, but Albuquerque learned it is probably the abnormality of the vein in cervical region or in dorsal region is the same pathophysiology of the dural AVM in spinal cord. Okay. To conclude, permanent stasis in the intraspinal plexus through excessive supply or insufficient drainage abnormality is possible, have a paraparesia or neurological deficit. Okay, this is one case. This is COP, I don't know, a special case. Okay. This is, just a minute, I want to show only two cases. Okay. This patient have a paravertebral AVM, no intradural, extradural. Come in the hospital with paraparesia, severe paraparesia, and look here, you are the flow vein going to the spinal vein, and this is the origin of paraparesia. After treatment, the patient recover. And you have the normal drainage vein. And this is the onyx. Okay. Just a minute. Sometimes bleeding. Okay. And this is the example to Dr. Saatci. Is one patient is treated 20 years before with a superficial venous angioma by surgery, plastic surgery, and the magnetic MR, you are a vessel around, hypertrophy of vessel around the spinal canal. You don't have here the magnetic. And, okay, this is the magnetic resonance. You are some vascular imaging around the canal, and the patient have a very high pain, dorsal pain, very difficult to treat it. Angiographic, arterial and medular, angiographic, no have a lesion, normal. The drainage venous is normal. At the same time, I have this imaging, I decide to check the venous component on the spinal region, and look, this is in AP view and lateral view, the vein, and you are hypertrophy on the drainage of this vein in the canal and in the foramen. is the origin of the pain of the patient. I think Alberto stayed with me in this period. I decided to treat it in 3 levels with coiling to stop the flow going to the canal, and the patient total recovery the pain, and the patient about have 6 years or 7 years is perfect. Okay, sometimes the pain of lumbar or dorsal is not only the mass effect of the malformation, maybe is the vein. Okay.